Alright, this week's all about antimicrobials. We'll first start talking about antibacterials. There are two major types of bacteria. We break them down into gram-positives and gram-negatives. When you look at your gram-positives, they tend to be purple, and this one looks kind of blue. And then you do gram-negatives, they look red. And this is just all based on what type of stain they take up. But we see our different antimicrobials. Sometimes they work better on one versus the other. We also have shapes that are specific, like cocci are going to be your round ones, bacillus are going to be rods, and then spirillum look like spirals. Cool. We have a lot of helpful bacteria in our body, your natural flora, especially in the gut, that does a lot of things that help with regular digestion and potentially food allergies, Crohn's disease, but we also have pathogenic bacteria, ones that will cause an illness. And those are the ones we're going to be focusing on today, right? When we talk about antibacterials, the major one is going to be your penicillins. These are originally from a penicillium mold. Here you can see the shape of a lot of your penicillins. And our other antibiotics, like your cephalosporins, carbapenems, and your monobactams, if you look, they all have this beta-lactam ring. This beta-lactam ring is going to inhibit the bacterial enzymes, these things called penicillin binding proteins, or PBPs. And your bacteria need these enzymes to make a healthy cell wall, right? And if they can't do that, if they make a defective cell wall, it's going to cause the bacteria to release these autolytic enzymes, and so then it ends up killing itself. That's a good thing about bacteria, is they are different from our regular cells because they do have cell walls. Something that we'll talk about when we get to protists is they don't have cell walls. And so it's really hard to attack those cells specifically because they are very similar to our cells. Another way to attack bacteria is they have a different type of ribosome than we do. And so you can either attack the ribosome or you can attack the cell wall. Our beta-lactam drugs, this group right here, use this beta-lactam ring. This ring can also be destroyed by the bacteria using an enzyme called beta-lactase. And so we'll talk about antibiotic resistant bacteria that have this beta-lactase. Alright, so in our penicillins, you probably haven't taken a lot of these. The first generation, they have a really narrow antibacterial spectrum. They can work well on gram-positive staphylococcus or streptococcus, and that's about it, right? So really good with gram-positives. A lot of these have to be injected, all your penicillin Gs. Penicillin V, you can take PO. In your penicillinase resistant ones, so these are your resistant staphylococcal infections. Penicillinase is just another word for like beta-lactase. Just a way that these bacteria become resistant to penicillin with these enzymes. And you can have like oxacillin or nafcillin. Used to be that methicillin was the go-to. It was a very effective penicillin, but now there is a group of Staphylococcus aureus that has become resistant, and that's what MRSA, right? Methicillin resistant Staph aureus is what it's called, right? And so they have developed or mutated with this enzyme that stops your penicillins from being effective. Penicillinases or beta-lactases. Alright. Getting into your second generation, these are probably more of the penicillins that you've probably taken, like amoxicillin, maybe augmentin, which is a combo amoxicillin and clavulanic acid, ampicillin, and then ampicillin combo. These have a lot broader spectrum, as you see as we go through the generations. Second generation has a broader spectrum. Third generation has an even wider spectrum. And then fourth generation has a super wide spectrum. And we start pairing them with beta-lactamase inhibitors. That's what this acid is with augmentin. So you take amoxicillin plus you get a beta-lactamase inhibitor that will also affect anything that is antibacterial resistant, right? Okay, so second generation amoxicillin, ampicillins. Of the two, you probably have had amoxicillin if you're not allergic to penicillin. Amoxicillin, I mean, they have the same spectrum, ampicillin and amoxicillin, but amoxicillin, it gets absorbed a lot better, and so typically that's going to be the one that gets prescribed. Getting down into your third generation, probably have not had any of these unless you've had some serious gram-negative infections. With your second generation, these work on both gram-positive and gram-negative. Just kind of like on your common gram-negatives, there are some gram-negatives that it doesn't really respond to, but for most of them it works. Getting into your third generation, for serious infections, like you have got to be put into the hospital for this, especially for vulgaris and aeruginosis. Only for the treatment of urinary tract infections for TICAR, broad spectrum, for pseudomonal infections, for Timentin, also Timentin for anemia-resistant infections. Getting into your fourth generation, again, same thing, very serious gram-negative infections, like pneumonias and aeruginosis. Again, probably have not had any of these, and Zosyn is going to be a combo with your tazobactam, which is your beta-lactamase inhibitor, with piperacillin. A difference too, so, you know, these are for very serious infections. For the difference between your third and fourth generation too is that your third generation used disodium salts, and your fourth generation uses monosodium salts. So if somebody is on a low sodium diet for heart problems, probably need to give them the fourth generation instead of the third generation, just to decrease that overall salt intake. Kind of like a side note. Alright, so our beta-lactamase inhibitors include your carbapenems, similar to your Gen 4 penicillins, and so you use them with your beta-lactamase resistance. You can see they're very good against serious gram-negative infections, just like the 4th gen penicillins. All IV/IM injections. And then down to your monobactam, we only have one. Also used really good against highly resistant to those that are beta-lactamases. So if you have a very resistant bacteria, they may include the monobactam aztactam to your antibiotic treatment. The next group, well, I guess kind of like a side effect, penicillin allergies is the most common drug allergy out there. And so these other groups that we're talking about are for people who are penicillin allergic. Typically, you will be getting second generation penicillins if you have a bacterial infection, unless you're allergic to it, right? So probably amoxicillin for a lot of your infections. If you are allergic to penicillin, then you might get cephalosporins. With your cephalosporins, you're going to see a common theme in the naming. They all start with ceph. That's how you know you're dealing with a cephalosporin. They're antibacterial, just like your penicillins, using the same mode of action. We just use it if you are allergic to penicillin. Typically, these guys are more resistant to the beta-lactamase, and so you might not have so much combos with other beta-lactamase drugs. Looking at our first generation of cephalosporins, really good against gram-positive and gram-negative infections, including different types of pneumonia. Cefazolin is preferred for chemoprophylaxis. So if you need to take an antibiotic because you have a weakened immune system or whatever, and you have to take them before you get sick, and you're allergic to penicillin, you will get cefazolin. Cephalexin is another one that is commonly prescribed. Again, good against gram-positive and negative, especially upper respiratory urinary tract infections. Our second generation, this is kind of like your penicillins, where they get broader as you go down and also more resistant to beta-lactamases. In your second generation, these are really good against like gonorrhea, H. influenzae, and pneumonia. Moving down to your third generation, again, this is for severe infections. Like you have to go to the hospital to get these, right? Especially to those that are resistant to other cephalosporins, pneumonia, aeruginosis. Rocephin, this one is really important because it can cross the blood-brain barrier and is typically used to treat meningitis. But these other ones are good at treating like gonorrhea, typhoid, pneumonia, pyelonephritis. And then your fourth one, cefepime, again, similar to your third generation, even better resistance to your beta-lactamases, very broad spectrum, which means it covers a lot of different bacterial types. And only indicated, so you're only going to use cefepime when these don't work. The reason we step them up too is like, the less you use these drugs, the less chance that bacteria is going to be resistant to it, right? Side effects with your oral cephalosporins are going to be GI issues like diarrhea. You can also get rash, especially at the injection site for a lot of these. First gen can cause nephrotoxicity, especially in people with renal impairments. Some may impair blood coagulation. And like penicillin, there is an incident of allergy, like you can become allergic to cephalosporins, but odds are it's a lot less than being allergic to penicillin, right? Our next group is the aminoglycosides, and we'll pick up with them next.